Welcome everyone. It looks like we are just about ready to go ahead and get started. So first off, I would like to thank you all so much for joining us this evening. And before we jump into the material tonight, just a few housekeeping items. Now, you all are muted on the call, so we can't hear verbally any comments or questions. But if you do have any questions during the presentation, please type those into the Q&A box on the right-hand side of your screen. And you may need to escape out of full screen mode to see that box. Also, the webinar will be recorded, and you will be sent a follow-up email with the link tomorrow morning, so you can view it at any time, share it with colleagues if you would like to do that. Now, for tonight, we are doing something a little different since we know how much our customers and supporters love asking questions. Instead of being a topic, we have asked you to submit your questions and kind of direct the presentation. So we have compiled a list of the great questions we received, and Dr. Kutsch will be going through those tonight. So with that, I would like to go ahead and introduce Dr. Kutsch, CEO and founder of Oral Biotech in the CariFree system. Dr. Kutsch has been successfully practicing dentistry for over 30 years and still practices 3 days a week here in Albany, Oregon. He has an incredible passion for what he does, and his vision to create effective camber protocols continues to drive in his research to improve caries diagnosis and treatment. So, Dr. Kutsch, I will let you take it from here.
Well, Kendall, everybody can hear me okay? I'm really excited about tonight's program. I think it's, I always enjoy the webinars, and tonight we're going to do something a little different, so it'll be kind of fun. I got Kendall sent me the questions this morning. They've been coming in from you all, so I really appreciate that. There were some great questions, and I think some really good points to go over and you know, help gain clarity with. So I'd like to start tonight through a CariFree case of the month. I've been doing this with my team here actually at CariFree. We're going through a case of the week, and this is actually my case of the week today, and so I thought it would be really a fun case to just include tonight. And, you know, there are questions on the CariScreen meter, and there are questions on compliance and, you know, language. How do you do this? And so we're going to address those questions tonight. And I think actually this is my first webinar we've ever done where we might get done on time. So I think you'll all appreciate that. And hopefully we'll have time to even take some live questions as they come in tonight too. Some things I've been teaching for last year, almost 2 years now, is really to think about the usual suspects. My experience with dental care is that typically when I sit with a patient who is high risk and has some issues, and, you know, boil down, going their risk assessment, it really typically comes to one or maybe two risk factors that are driving the majority of their disease. There are one or two factors that really stand out, and, you know, it really helps us so it's not so complicated for us, you know, in terms of diagnosis, and it's also helpful for the patient. It's not like I'm throwing 100 things at them that they need to change. One of the greatest challenges is not making the whatever protocols you want to implement with the patient too complex. The simpler that you keep it, the better. If there's only one thing that needs to be changed or one new additional procedure that they need to add to their protocols or their daily hygiene schedule, if you can get it done to one thing, that's where you're going to have the opportunity to be successful in terms of behavioral change working with your patient. So I kind of term these the usual suspects, and really those are bacteria and diet and saliva. And if the suspect is bacteria, typically they either have too much bacteria or they have the wrong bacteria in their mouth. If it's a dietary issue, it's typically that they're snacking too frequently during the day. And more often than not, as I go through these cases, it comes down to what they're drinking rather than what they're eating. And typically they're drinking, something that has a lot of sugar in it, and they're sipping it throughout the day rather than, having it at one time. Or it's a hidden sugar, and they're not even aware of the fact that they're consuming sugar. You go look at some of the waters. You go to the Quick Marts and you walk in and pull open the refrigerator door, and you start looking at the labels. You think waters. It's amazing. People are consuming. There's an ad now running in the state of Oregon by I think it's sponsored by our Association of Dental Association, but it shows this person sitting down with a 20-ounce soda. First, he's eating packets of sugar and literally demonstrating that there's 20 packets of sugar in this one soda, and nobody would sit down and eat 16 packets of sugar, but when they drink a 20-ounce soda, they don't really the fact that that's what they're consuming. So there's a lot of hidden sugars in our diet, and that's an issue for us. Saliva is a major problem for, I think, most of our patients and for most of our senior patients. Most of that is medication related, and so they don't have enough saliva, so they have medication-induced xerostomia, and the saliva provides the main pH balance in the mouth and all those protective factors, and so without the saliva, things go south in a hurry. But at the end of the day, it all comes down to our old buddy, Kutsch say, it's all about the pH. So on which of these usual suspects is driving that in these patients, it always comes down to pH at the end of the day. So I like to have people start to think about, when you see the patient, start looking, what do I see? Do I see saliva? Do I see bacterial plaque built up on the teeth? Obviously, you're not going to look in their mouth and see their diet, but you start to get a sense for immediately, as somebody that has high bacterial load, do I see a lot of plaque? Do I have a dry mouth? Those are kind of clues that you should recognize right out of the gate, so you kind of have an anticipation of where to direct your questions with the patient. My patient here came to see me earlier this year. He's 65 years old, blood pressure and puller within reasonable limits. He suffers from Parkinson's disease. He's had Parkinson's disease for 10 years now. He also has emphysema. The emphysema is secondary to a history of cigarette smoking. He's currently on 8 medications that he takes daily. And so we look at his mouth, and, the first thing you start to identify is, bacteria. So does he have a lot of plaque buildup on his teeth? Yeah, I see quite a bit of plaque. I don't know what his diet's like, but the second point is I see quite a bit of saliva. So tissue's wet and you see saliva pooling in the back of the mouth. I think this is an interesting patient from the standpoint, typically when I see a patient that has 8 medications, and all of those are, most of those are medications that would certainly reduce salivary flow, I'm anticipating to see a dry mouth, and I look in his mouth and all the photos I have of him, and he's got saliva bubbling everywhere. And I think it's important for us to recognize that about 20-25% of patients that are on 8 or more medications don't have a reduction in salivary flow. So while it's a problem for, let's say, 80% of our patients, you're going to see the patient where that isn't an issue. And so we look at the radiographs, and you see the obvious decay. He's missing all of his molars, but yet he has good bone support around all of his teeth. So I'm not expecting that he lost his molars due to periodontal disease, and he doesn't really remember whether, never told him he had periodontal disease. He obviously has some, calculus buildup here and there, but that's more from a lack of, or neglect from true periodontal disease, and his susceptibility. So I'm really anticipating he probably lost most of those teeth due to dental caries, because he has dental caries pretty much his entire mouth. So his risk assessment form, and here's a patient who interested in a free screen today. He wants to talk about it. He's willing to modify his diet and his self-reported risk factors. He notices a plaque build on his teeth. His home care was pretty intermittent. I guess would be the best way to describe it. He'd not seen a dentist in a number of years. He'd never replaced those missing teeth in the front. But he is 65 years old, and he's at a point in time where he realizes that he's going to lose his teeth if he doesn't do something. He doesn't want to go to dentures, and so he came to see me as a new patient. I said that he has 8 medications he takes on a daily basis, and I shared those with you. And then he wrote down that he snacks daily, between meals. So I went through the risk and started asking him questions about this. Turn snacks maybe once a day. And so the real issue with snacking is not what you're snacking on. More importantly, if we back to the Stefan curve and John Firstone's research, the real risk factor is if you're snacking 3 or more times a day between meals. And really that's a function of the pH. The more frequently you eat, or let's say sip of soda, the more time that you spend, that patient spends below the remineralization pH of 5.5. So you don't have a healthy balance, and you end up with that mineral loss, and it also then creates that shift toward these acid uric bacteria that cause dental caries. So I think that's a real issue for most people. I'm sitting there talking to this patient, and it's like, yeah, I snack maybe once a day in between meals. My other 3 meals are pretty steady. He's not drinking sodas, doesn't do any of that. So as I look at those risk factors, we get down to the disease indicators. He has new progressing visible cavitations. He has proximal radiographic radiolucencies. He has active white spot lesions, and his decay history certainly is a concern here to me. So he's, he's kind of in the red zone there. Everything is yes. Then we're down to the biofilm challenge, and he has a high biofilm challenge, which is what I would expect on a patient to see on a patient like this. But he has plenty of saliva, but he had a high biofilm challenge. So as we go through the professional assessment summary, then, in my mind, his risk factors are a concern to me, particularly the plaque or the bacterial load, the disease indicators, the white lesions and the progressing lesions that he has are a concern. His high biofilm challenge is a concern. And so as we go down to our risk identification, then get down to our grid, he profiles in as a patient number 5. He's higher extreme risk. I would classify him as an extreme risk patient. And he's somebody that, as we started going through coaching language with him, that wanted to pursue recommended treatment. We wanted to get started kind of immediately. So, my assessment here is risk factors, everything's a concern. And my usual suspect here is bacteria. I'm thinking that he's got too much bacteria and he's got the wrong kind of bacteria. So with the plaque buildup, that's where we're going to start. So my diagnosis, he's a type 5 extreme risk. So as we get into the wellness coaching, and we've been doing this for a couple of webinars now where I've started to introduce the concept of the coaching language, and this was developed by Ferocia Knight from the Brock Institute in Portland. This is probably a really good time for me to tell you that we've just finished publishing, Bob Bowers and I finished publishing our first book titled Balance on Dental Caries. I know that some of you have already called and requested copies of that. If you haven't, I would certainly invite you to do that, where we really took dental caries and tried to explain, based on all of the scientific information that we have, what causes this disease and what different options are available for types of therapies and how do you deal with it. The next step in this process is how do we manage that high-risk patient through making the behavioral changes so that they can be successful in achieving wellness in their life. That really is a coaching skill. I know exactly what you need to do to have a cavity again for the rest of your life, but in dental school I wasn't trained on how to make that happen. So I didn't know how to help the patient work through that process of behavioral change. So I went back to school and working on going to a wellness coaching program, actually with Ferocia. And so Ferocia and I have gotten together. We're going to be writing a book together on wellness coaching for the dental professional. So look for that book to be out early next year. That's our commitment, and I'm pretty excited about that. So this is some of Ferocia's material that she's developed over the years. But, you start with the focus. What is this patient's real focus? What is his goal here? And, what he expressed to me was that, listen, I want to save my teeth. I don't want to lose any more teeth. In fact, I'd like to replace the teeth that are missing in front. I don't know what my options are for that, but help me. I don't want to lose my teeth. Outlook for the patient, his biggest challenge was financial. We has worked through and figured out how he can afford to have all of the dental care done. His greatest challenge, I think, is Parkinson's disease. He have tremors, and so his coordination is not optimal. So certainly when we start talking about oral hygiene and his daily hygiene regimen, that's something that we're going to need to consider, and I put him into an electronic toothbrush to help him with that as well. The opportunities here, the things we've got on the plus side of the equation, is this person is strongly committed. He hasn't taken good care of his teeth. He didn't have good daily hygiene. He's lost a lot of teeth. But here's somebody who's kind of had a wake-up call and said, I'm ready to make a change in my life, and I want to do this. I want to save my teeth, and whatever I need to do, I'm going to work with you. I'm going to make it happen. So he gave me a great deal of confidence that here's a person who honestly is clear about what their goal is here and is committed to make that happen. So that's a huge aspect for us, and that was one of the questions tonight, and so we'll talk about that some more as we get to that question. But if the patient isn't clear about what their goal is, or if they're not totally committed to it, you're going to be successful, and they may blame you, or you may want assign yourself some of the blame on that. But the reality is they need to be really clear about what it is that they want, and they need to make the commitment and have an honest commitment made about it. And then the tactical plan, or what targeted action are we we going to take? And so he immediately, wanted to begin working on the biofilm, getting healthy bacteria going in his mouth. We needed to do restorations on teeth that have lesions, and then we were going to stage that treatment, do it kind of segment by segment throughout his mouth, continue him on the biomodulation as watch his numbers come down, and then work on wellness long term, replace the missing teeth and just work on a regular care for this individual for wellness. So, again, here he is at the age where we've repaired the lesions in his mouth. We've been working on the biofilm modulation now for over 3 months. Today I would put a patient like this in ionomers. He expressed to me enough motivation and interest and commitment that I went ahead and placed composites in those areas. It's one of those kind of critical thinking things. You need to make a decision. Am I going to place glass ionomer? I'm going to place composite. So I feel comfortable doing that for this patient. I hope I made the right decision. I'll know a year or 2 years from now. But I'm pretty confident that where we're headed. The question is, what do you think we should do? I throw that out to the patient. They always want you to tell them what to do. And the reality is, if you want them to have clarity and you want them to go accomplish their goal, it's like you need to ask them. I just scratch my head when they ask me, well, where to start? What do we do? And I say, well, what do you think we should do? And they always have ideas. And I go with their ideas. It's like, oh, yeah, that's a great idea. We need to repair all the cavities that you have. Yep, we need to start there. Yep, we need to get your teeth cleaned. Yep, we need to start working on these the bacterial load, work on your home care, work on reducing the bacterial load. And so that's part of the coaching language on how we approach working with patient. And then, what is going to work best for you? When we're talking about making behavioral change, what works for you? I can tell you exactly what works for me, and I'll share that with patients. For me, I need to make a list. I need to make a note to remind myself. As long as I have a note reminder, I'll follow through and I'll make it happen. But if I don't have that reminder, it's a breakdown and I don't make the change. So maybe I do it for 2 or 3 days and then it slowly breaks down. That's me. So, they know themselves best, and they need to tell me what works best for you, and let's figure out a plan that works. And then where do you start? So this is this patient when he first came to see me, and here he is today. Actually, I took this photograph this afternoon. We placed his partial denture to replace those teeth in the front. And you can see he's doing a good job of brushing his teeth, and he's made a lot of improvement there. So I'm really pleased with where we're headed. His numbers are down from on the screen, so he's making great improvement. He's doing a great job. I'm really pleased with his progress. And I'm in the mirror today, and of course he's missing those teeth for over 20 years, and he teared up and thanked me, and it was like. Then I teared up, and then my assistant teared up, and it's like, but those are the best days that I have in my office when you get to help somebody and make a real life-changing experience for them. So, he's headed to wellness, and we're going to continue to work on that, continue to work with him. So I just wanted to share that case with you. That was my case of the month for CariFree. But those are the kind of things that are possible for you to be able to do easily in your own practice, and have the confidence that this patient is going to be healthy 2 years from now, and that you're not going to be sitting back here with more decay, new decay around all those restorations that you just placed, because we've all seen that in our practice, and I'm done doing that. So question number 1 that came in this week, and sent these to me this morning, and so I thought I actually answered them and worked on them today a little bit. A lot of it is spontaneous, but I thought it would be fun to give you some answers that I had worked on. What verbiage should I use on patients who don't see results after the first round of treatment and are hesitant to continue? And I think that's a challenge for us, regardless of what we're talking about, whether it's weight loss or blood pressure or whatever it is that a patient or a person trying to make in terms of a change in their life. Which is not linear, and it's not always successful. And when we come to dental caries is a complex biofilm disease. And I have to tell you that when I started doing this 13 years ago now, I really was looking for a silver bullet. And I think we're still looking for a silver bullet. This is like pervasive in our society. We look for a silver bullet. Just give me the pill. Just give me the vaccine. Just tell me, what the least active thing I have to do, or let's say the most passive path I can have to success. Invent the magic pill I can take and still eat everything that I want, and I'm going to lose weight. Well, life doesn't work that way. And I really thought that we would have this disease cured by now. I thought that this is a 30-day process. I'd have these people healthy. I'd test their bacteria again in 30 days, and everything was going to come right very quickly. And for some patients that happens. But before I get into this, changing biofilms, altering human behaviors is a longer process than I think I appreciated. And every day I read about some new magical molecule that's going to eliminate dental caries, or some new vaccine, or some new probiotic, or some new this or that. The bottom line is they haven't yet. They're not going to. This is a complex disease, and when you've got the number of risk factors that we have, and now the number of pathogens that play a role, and the point is it's not even pathogen specific anymore. It's really more about the behaviors of the bacteria. We need to start looking at what's happening environmentally in the mouth, and less about who's there if we're successful at treating this disease. So that really falls into the patient has an expectation that this is going to be over in 90 days or 30 days or 90 days. I'm going to take this magic rinse and boom, I'm going to be healthy. And maybe that doesn't happen for everybody. The one thing that we know about biofilms is that they're very resistant to change. In the clinical trial that we did in Australia, we saw continued change in the biofilm over 2 years when they were using, these kids were using treatment rinse. So it's not an overnight proposition. Didn't happen, the situation that they're in as a high-risk patient or extreme risk didn't happen overnight. It may have been accumulation like the patient I showed you tonight. There's easily 20, 30 years of development that took to get to that point. I'm not going to fix that overnight. That it doesn't work that way. It takes you 30 years to gain 100 pounds and be overweight. You're not going to lose 100 pounds in 30 days. It's a long-term proposition to get out of that. So I think that we need to not overpromise and underdeliver. I think that's one of the greatest challenges that we have. We want the patient to think like it's going to be successful overnight. No, it's going to be easy. And the reality is, this takes some commitment on their part, and it's going to take some time. I was at Cleveland Clinic earlier this summer, and the behavioral studies that they're doing at the Cleveland Clinic now would tell us that we used to think that it took 20 days to establish a new habit. That's kind of the Japanese behavioral studies. That's the model. Boom, 28 days and you got a new habit. It turns out in wellness and the coaching and the wellness program they're doing at the Cleveland Clinic with Michael Roizen, it takes 9 months for us to establish and have a sustainable new habit. The short-term fix may give them a new habit for a while, but if you want a long-term sustainable change in their behavior, that's a 9-month proposition. And so I think it's kind of an awakening for us all to start, having an understanding that this may not happen overnight. So it's discouraging. So what I tell the patient? I tell the patient we're not done yet. It's like these biofilm, these bacteria are, is resistant to change. We're going to do it again for another 3 months. We'll test you again. But this may take a while for this to change. Part of that then, too, is I also want to have the conversation, so how is it going? Are you using it every day? Have you been able to make that change in your behavior? Are you using the rinse every day? Are you doing that? How is it going? What's working well? What's not working? What kind of things? How could we make it better for you so that it works better for you? And again, other than me telling here's what you should do, it's like, well, what do you think would work better? What could you make that would make this more successful for you? And have the patient always put the work back on the patient, because if it's their idea and their decision, they know themselves better than you do. And if they come up with the idea, the greater the likelihood is that it's going to be successful for them. So I want to reinforce whatever is working well and their behavioral change they've made. I don't want to discourage them, and I want to be honest with them in terms about having a realistic expectation about how long this may take. Patients that I treat, by the time I get them completely restored and I get them to a point where I think they're stable and well, it may be a 3-year process. And different than what I thought, 10, 11, 12 years ago. And I think, in dentistry we're taught, you identify the hole, you fill it, boom, you're done. Kind of the instant orthodontic solution, it's like veneers. We're all looking for that kind of answer, and really we need to go back and take our time. And the other thing I would tell you, too, is go back and look for risk factors. Make sure you haven't missed anything. go back, look at their saliva again, ask them again about their diet, and tell them that I just want to make sure I haven't missed anything that's important for us to know to help you be successful. So the silver bullet mentality that we all have and our patients have, and so what's discouraging? You go in with a realistic expectation, I think, you're going to meet with greater success. I would share with you, I ordered a drift boat in March this year, and they told me that it would take, I ordered it in March, the 1st of March, because I wanted it to use all summer long, and they take 8 weeks. So at 8 weeks, I gave them a phone call, so how's the drift boat, what's the delivery like, what, how things going? Well, it's going to be, another 4 weeks. So I call them back in 4 weeks, no big deal. Well, it's probably going to be another 2 weeks. Every week I called this company, and I finally got the boat. I picked it up 2 weeks ago. So it took them 6 months, over 6 months to deliver this boat. And they originally told me it was going to take 8 weeks. It was a pretty big experience for me. I got to tell you, it's a great boat, but the experience was rotten. And I didn't get to use it this summer. I got to use it for 3 hours. And if they had said to me, look, this is going to take 6 months. We hope to get it to you sometime in September. If things go well, I said fine, and I'd have called them in September, and it would have been a positive experience. But that silver bullet thing turned into a bad experience. Question number 2, how can I improve patient compliance and acceptance? This is a great challenge when we're trying to work with our patients to make change, whether it's in periodontal disease or caries. Compliance, and I really don't like the word compliance. I really like adherence better, or participation. How do I, make improvements in that? And I tell you, if the question to ask yourself is, am I working with my agenda, or am I working with their agenda? If I told them what I think that they should do, I'm with my agenda. If I've had a conversation with them and I ask them, what do you want to do? What is your goal? How will I know a year from now that I was successful for you? What kind of things do you want to do so that I know that I've been successful? What is it you're really trying to achieve here? If you can get a patient completely clear on answering those questions, the great likelihood that you're going to have compliance and acceptance and participation from the patient. So, in coaching we use the term radical clarity. The patients that I have that are radically clear, I don't want to lose my teeth. That's my focus. I don't want to lose my teeth. And typically it comes down to this: I don't want to save my teeth, or I don't want to have any more cavities. I'm done having cavities. I want to be done with that. Show me how to stop getting cavities. But if the patient completely clear on what it is that their primary focus is, their primary goal is, the great likelihood that they're going to feel it and own it and do something about it. Because if they're not clear, well, I kind of want to do this, and sometimes I'll have patients that will come back and they're not really participating, and I'll say, so, I want to ask you this. You told me that this was your goal, and it doesn't feel like it to me. Like, I don't see you doing the things that are going to be necessary to make that happen. So I'm wondering if that's really your goal, or if there's something else that you'd really rather do. And, or is there something else? Tell me. I'm here to support you. Let me know what your goal is. So the real question is what's your here? And I ask the patient, what do you want to focus on? And I want to make sure that we're really clear, and you use your active listening skills. It sounds to me like what you're trying to accomplish is, did I get that right? And back to the patient, I want to make sure that I understand what it is that you're telling me, so that I can make sure that you and I are on the same page. Then I can help you identify, the pathway for yourself to get there. That's my role as a coach, to help them make that decision. So I think as long as I'm talking and as long as I'm providing the information, it's my agenda. And when I shut up and I start asking questions, I get to find out what their true agenda is. And, that's where we're going to be a lot more successful. But again, those are communication skills that we're not taught in dentistry. We're taught to educate. We're taught to provide information. We're not really taught how to listen well. And we listen to our patients carefully, and we ask powerful questions, open-ended questions. We'll find out really where they're coming from and what their real goal or what their real focus is. And at the same time, it has then become really clear about what it is that their focus is also. As they process through that and start to verbalize what their focus is, they get real clear about it as well. And once you have a patient that's clear about what they want, I have seen patients make unbelievable radical change in their life and sustainable change. So I'm talking 3, 4, 5 years down the road. So, but it takes that kind of clarity. So that's the thing that I would challenge you with is, if you want to know how to improve compliance, it's about telling them they need to floss twice a day. It's not showing them how to floss. It's asking them the questions about, what are you trying to accomplish here? So, and then kind of coaching them through that process. Our screen readings seem to be inconsistent. Is this a valid assessment tool? How do I explain a low reading to a patient who has decay? Well, there's actually, I think, 2 here, or 3, but I bet really good questions, and those come up pretty frequently. Is this a valid assessment tool? I have to tell you that I'm extremely confident in this tool at this point in time. I've been using it for, I think, 9 years now. And when I first started, I got a lot of criticism because it was non-bacterial specific. It was measuring all the bacterial load. And then as some of Featherstone's research, continued to develop and indicated that actually the bacterial load, while bacterial load was probably the #1 risk factor after all the disease indicators, suddenly we have a non-specific device that measures overall bacterial load in 15 seconds, chair side, and gives you a real quick read on what's the load, what's going on in this patient's mouth. Based on a lot of the independent studies that we've done and other independent studies, university-based studies that have been done and reported at the IER, the ADR, different researchers, and we've looked at mothers and children, mother-children pairs. We've looked at adults. We've looked at children. We've looked at all age groups. Not a major bacterial load, but it actually correlates high significance, correlates strong correlation to their caries risk, and also correlates strongly to the mutant streptococci that are present. Those are bacteria that we identified and tested for and looked at in these different populations. So I think that it has a valid assessment tool. I don't know how much more research people need, and I use it every day and depend on it. Dr. Featherstone has implemented as a standard of care at UCSF. In the clinic there, a lot of dental schools are using it. There's a lot of research going on with it. The next question becomes, I think, a great challenge, and that's how do I explain a low reading to a patient with decay? And you start to look at our new professional assessment summary, our new risk assessment form that we introduced earlier this year. The CariScreen readers measures basically ATP. That's all it measures. There's either ATP there or there isn't. If it's present on the surface of the teeth in the biofilm, it's probably more likely bacterial than it is somatic. So it measures ATP. People tell me, well, I got this reading. No, you didn't get an erroneous reading. It told you exactly how much ATP was present, and it's very accurate at measuring that. The challenge becomes, and what do you do with that piece of data? How do you interpret that? So we know that it measures bacterial load, biofilm activity, and caries risk, but it does not measure cavities. It doesn't measure the presence of cavities. So, you go down to our risk identification here. The low risk, the #1, well, they're low risk. They have no biofilm challenge, or they have a low biofilm challenge below an ATP score of 1,500. You expect that. So that's normal, no problem. You go to the moderate risk, and I'm not really expecting a biofilm challenge there either. They probably have one risk factor maybe, and no disease indicators, no cavities. And so again, they come in with a low biofilm challenge, and you expect that. That's not a problem. You got to the #5 patient, and here's a patient like I showed you tonight, and I'm expecting to see a high biofilm challenge in that patient. When I see it, it's consistent. The challenge becomes the patient's #3 and #4. #3, when you've got a person that has a high biofilm challenge, they've got a high CariScreen score, but they don't have any cavities, right? Or you've got the patient that has #4 who has cavities, but they have a low score. And so that's where we don't anticipate, that's an unexpected reading. And let me talk to you a little bit about what that data means, because for the first time, as we've been measuring these things over the last 4 or 5 years, we got pretty clear on this about 2 or 3 years ago, and just in my own experience using it. When I look at that number 3 patient, here's a patient who's got a high biofilm score, but they don't have any cavities. So this is a person that could benefit from an antimicrobial agent like the CTX4 rinse to reduce their biofilm challenge. It seemed to be I get challenging reading from the standpoint of, gee, they don't have any cavities, yet they have a high score. We didn't anticipate, that was an unanticipated reading, but I would tell you more likely that here's a patient that's like, for a good example, a patient with high blood pressure, but hasn't had a stroke. Just blood pressure doesn't mean they're going to have a stroke. This person, it puts them at risk. It puts them at risk for cavities, but they may have enough protective balancing factors in their life and the environment of their mouth that it hasn't expressed the disease. So are they comfortable living with that high biofilm challenge? If they are, hey, I don't have any problem with that. But if there's a change in the environment, they may end up with a real issue. You could have a patient that has a high biofilm challenge, hasn't had a cavity in 30 years, was diagnosed in June with sleep apnea, is now on a CPAP machine, and suddenly the entire environment of their mouth changes like 8 hours out of the day. And, they're xerostomach and they come to you complaining of a dry mouth, and if that patient has remedied them the situation by putting a cough drop in their mouth, not a sugar-free cough drop before they go to bed, you're going to see a nightmare in about a matter of 3 to 6 months. So the challenge isn't a challenge as long as everything's okay, but when that environment changes, then things happen in a hurry. When you get to the number 4 patient, and this is the one where they have the cavities, but they have a low biofilm challenge, typically this patient, what this tells you is this person has a disease, but it's not because they have too much bacterial load, or it's not because they have necessarily a high bacterial load of the wrong bacteria. This is a function of something else is going on, and it may be on the protective side of the equation. They may not have enough saliva. Typically, when I look at a number 4 patient, in my experience, and I've had a lot of different people, give me ideas and what they see anecdotally, but I have to tell you clinically, when I see a patient number 4, typically in my experience, we're talking about a xerostomach patient. They don't have enough saliva. So here's a patient who isn't going to benefit from the CTX4 rinse. They don't have a bacterial load issue. Their problem is they don't have a high enough protective factor. They don't have enough saliva. They don't have whatever else it might be. They don't have enough of that, and we need to support that as we're trying to create a healthy caries balance and get to wellness. So hopefully it makes sense to you. You just need to have that understanding of the 1, 2, 3, 4, and 5 patient. If you're sitting with a number 4, you've got cavities. Erroneous, or it's not a challenge for me. It's actually a benefit because it identifies the patient that's going to benefit from the antimicrobial therapy versus the patient that's not going to benefit. Because there are a lot of patients that get put routinely on antimicrobial therapy, and and at the end of the day, it hasn't made any change at all for them. Well, that's a patient I would tell you didn't have that challenge to begin with. So for the first time, we have a biometric where we can actually support and make that decision and have some support for it. Question number 4, do we have to charge for the CariScreen swab test? No, actually, the answer to that is no. Yes, no, or maybe. It's strictly up to you. I have practices that charge for it. They like to itemize it. I think that's a good practice to do that, because when we utilize those insurance codes, the D1205, susceptibility testing, when we use those codes, there's a greater likelihood that we're going to see more employers look for insurance products that have coverage in those codes for their employees. So it's important for us to utilize insurance codes. Same point in time, I'm on both sides of this equation, and I would have to tell you from my practical experience, I threw in the towel probably a couple of years ago, and it was always, if it came down to $10, I charged $10 for the CariScreen in my practice. You have patients, well, is it covered by my insurance? Well, we won't know until we bill your insurance. Well, then I don't want to do it. Okay, it's $10. You don't want to know whether or not, you're not going to give me the data point, and I'm looking at this going, well, I don't know whether you would benefit from antimicrobial therapy or not, so I'm putting you on everybody gets put on the therapy, and it's like, it was such such a challenge for me that actually son gave the idea, he's also a practicing dentist, said, Dad, here's what I did. I just raised my prophy fee by $10, and I just include it as part of it. Now there's no argument. I can use it whenever I want, and anytime I want to do a swab, I'm free to do it. And so I did that about 2 years ago, and I have to tell you, it was a great thing. And I still have a small percentage of patients on that risk assessment form where it says, question number 1, would you like a free test, that say no. Say no, and they go, well, how much is it going to cost? Or does my insurance cover it? And it's like, do not see the word free, F-R-E-E. What part of that didn't you understand? I guess we live in society and we have a belief that nothing is free anymore. So even when I tell you it's free, it's not really free, but I included it. It's built into my prophy fee. So I would tell you, get comfortable. I like using the CariScreen. I like to have the ability to use it at my discretion and have a patient who's making a $10 decision whether or not to do that. I want that data point. It's really important for me to make best decisions and I think recommendations for the patient. So comfortable with however you go about it. You can charge more. I have practices charge as much as $25 or $30 for the test, and then there's practices that give it away and haven't increased their prophy fee. Whatever is comfortable for you is comfortable for me. So it's like, what do you think we should do about it? Here's the coaching language. How would you solve that in your own practice? What do you think we should do? So I would put the work back on you to answer that question. Question 5, my office doesn't have a meter. Will our program still be successful? And that's a great question. And it really isn't about having the meter or not having the meter. The success is really about your communication skills with the patient. Using that risk assessment form and identifying the risk, figuring out what's causing the patient's disease, and the only thing you won't have, you won't have that backload data. The rest of it you'll have, and it's the whole participation, and success and adherence from the patient. That's all really about your communication skills and helping the patient get clear about what they're trying to accomplish. So the question I would ask you, certainly I think you'd be successful without the meter. It's not a data point I'm willing to work with. That's why I took the strategy of raising my prophy fee and including the CariScreen for free so that I always have that data point when I want it. The question is, what are you giving up by not having the meter? And what you're giving up is a biometric. You're just literally up the standpoint of you're not going to be able to determine for those patients who aren't benefit, like that number 4 high-risk patient who has a no body challenge, you're probably going to put that patient on an antimicrobial therapy unnecessarily. They're not really going to benefit from it. So it's another data point. The other nice thing about it provides a surrogate endpoint for you so that, how do you know when you're done? Same kind of question comes up. If you don't have a surrogate endpoint like that, so that I can, 6 months or 9 months down the road, I'm retesting them every 3 months and looking for their bacterial load to come down. They don't have that endpoint. I can measure it objectively. Then somewhere along the line, I have to just guess about when I think the patient is healthy and we're okay. And my biometric then becomes, do they get a new cavity? Where I was before I got the P, before I developed this like 9 years ago. That's where I was at, and I wasn't happy with that. Biometric was, do you get I'm using bite wings, X-rays, and are you getting more cavities? And I know that we're still not there and I need to do more work. Well, I'm not really willing to are you getting more cavities as I guess the measure of my biometric to determine where I'm at with the patient. So, so the answer is yes, you can be very successful. It handicaps you a little bit in terms of the decisions that you make and also your endpoint. So, I'll decision up to you. A lot of people work without a meter. I'm comfortable with you working with or without a meter. It's whatever. Again, it's like, what do you think is going to work best in your own practice? What do you want to do? I would encourage you that I would say this: rather than letting the meter be a deal breaker for you, start with a system, we have System 1 that has just a risk assessment, a simple risk assessment that you're going to do, and a simple grid for the on protocol and treatment, and start with that, and start with some simple products rather than doing nothing. Sit there, and we have a lot of practices that do that, and after they start to get into it and go, you know what, I've more information, I want to do more, and then you can always add things like that to your equation. So I would say don't let that be the limiting factor for you. Number 6, what are recommendations in regards to probiotics? I don't use them. I guess that's probably the clearest way I could phrase that. Svante Schwetman is probably the world's leading expert in probiotics. Now, let me phrase that statement. I use them for dental caries. I think probiotics have been demonstrated in clinical trials for diarrhea and Crohn's disease and inflammatory bowel disease and all of that, intestinal, we travel. I only think that that's, the lactobacillus and, that works, and we have clinical trials for it. The challenge that we've got right at the moment in dentistry is probiotics need to meet several key points. It needs to be a live bacteria, and some of the things that are on the market being promoted as probiotics for dental caries are dead. But live bacteria, it has to have benefit or a value greater than just nutritional value. It has to actually do something to qualify. This is the World Health Organization definition of what a probiotic is. It needs to become a member of the biofilm, and it needs to provide a benefit. And it needs to provide a benefit for the target audience. So what challenges that I see in the research that's been done with probiotics is they'll use live bacteria. The study won't have caries, dental caries, as an endpoint. It'll be measuring whether or not this bacteria was present in the mouth. And the one thing that we're pretty consistent on in the terms of the outcomes of the research, they're transient. They don't really become permanent members of the biofilm, which means that the patient, to get any effect from it, has to take it every day for the rest of their life to get a benefit from it. And they're really very compelling research that indicates that there's a good anti-caries outcome. So when I start to look at those things, it's like at this point in time, I'm not using them. I'm actively interested in probiotics. If it was one more thing that we could utilize that would help patients, I keep reading the research and I'm open-minded to it. And I tell doctors and hygienists, if you want probiotics, try them, but don't depend on them. Depend on a probiotic to provide your anti-caries solution for the patient, because it's like the research just isn't there. In fact, this is Svante I at a meeting earlier in January of this year, and something I really appreciate about this research is that he reports negative results, and so you know that you got somebody you can trust their data, you can trust their results when they tell you this didn't work. He is convinced that at some point in time we will figure that out. He's optimistic, but this actually came across my desk today. This is in the September issue of Advances in Dental Research. This was the proceedings from our meeting. The available literature does not exclude the possibility that probiotic bacteria can interfere with the oral biofilm, but any clinical recommendation would be premature. Large-scale clinical studies with orally derived specific anti-caries candidates are still lacking. They looked at 19. They did a systematic review, looked at 19 papers. Only 3 of those had an anti-caries or caries outcome, and the results were not conclusive. So at this point in time, Svante says, they're fun, play with them, use them, try them, but there's more research that we need to do here. I'm cautiously optimistic. I think at some point in time I'll be recommending probiotics. At least I hope so. But at the present time, I think our research based on this was published this month. Our recommendations are still lacking. Number 7. Should I use MI paste along with the CTX4 Gel 5000, or does it replace it entirely? Another great question. And I think the answer to that is keep it simple. When you look at CTX4 Gel 5000, it has a pH of 9.0. Now, one thing I would add on the MI Plus that's not on this graphic is it does have a pH. It's slightly alkaline. It has a pH of around 7.115. I think they list it somewhere around 7.8 7.3. When we it comes in at about 7.15, so it's basically neutral. We're trying to drive that pH up, so we use a pH of 9.0. They have obviously CCP present in it, so there's a remineralization strategy there that has a lot of research behind it, and some of them have fluoride, although lower levels of fluoride, not 5,000 parts per million. And so in my mind, xylitol, 5,000 part per million fluoride, which has an abundance of research on it for remineralization, and it's an anti-caries strategy. We are using nanoparticles of hydroxyapatite on the CTX4 Gel 5000, and it has a pH of 9.0. I think it's redundant to use both of them, so I would tell you to make your own decision. What do you think work best, and you decide to use which one that you want. But because I tell you, it's really important from a coaching standpoint. The things that we understand about making human behavioral change is that simpler that you make it, that it is. I really look for just a product substitution. Use this instead of your dentifrice. You're using toothpaste every day. Go home, use this instead. Don't use it in addition. Don't add any more steps. Don't make them do 16 different things during the day, because they're not going to. Just hand this to them and say, here, use this instead of what you're currently using. Or if you're using a mouth rinse, use this one instead of using what you're currently using. And that's going to be our approach to therapy, because the less that you add in terms of new behaviors that you expect them to do on a daily basis, the easier this equation becomes. And I certainly started out, I have to tell you, I started out 13 years ago. I had protocols for patients that even I probably wouldn't do if I were honest with myself. So we really need to just keep it simple. So no urgency, keep it simple. You decide what you want to use and go for it. This one comes up a lot, and so I wasn't surprised to see this question come in. Are there any crossover benefits with patients dealing with periodontal disease? And through the FDA clearance, marketing clearance to market any of our products to treat periodontal disease, so my answer as a manufacturer is I cannot prescribe or recommend that you use it to treat periodontal disease. However, let's look at some anecdotal reports, and when we start to talk about certainly the antimicrobial agent that we have in the CTX4 rinse, it's broad spectrum. It is non-specific. It reduces your overall bacterial load. It's going to kill caries pathogens. It's going to kill periodontal pathogens. And yes, it's going to kill the normal, healthy commensal pathogens. And guess what? Those are bugs that grow back. The early colonizers are the healthy bacteria. They grow back. They recolonize the mouth first. And as long as you support a healthy pH, you're going to get them to return, and that's nature. If all that grew back was the bad bugs, people would be getting worse and worse and worse, and that's not the case. And I've listened to researchers make claims without any scientific support whatsoever, using a broad spectrum antimicrobial agent, and all you're going to end up with is the bad bugs. And it's like, really? Because that doesn't even make sense. So because it's those healthy bugs that reestablish the mouth, they reestablish the mouth first. That's why they're early colonizers. The body has an incredible capacity for wellness. We just have to provide the environment for that to occur. So if you raise the pH and you're supporting that, you're going to get a healthy biofilm back. Are you going to kill periodontal pathogens at the same time? Yes. One of the first things that everybody identifies and reports back to us, she put my patient on, my caries risk patient, for treatment rinse, and I saw them 3 weeks later, and their gums were pink and healthy, and it's like, yeah, that we see that. It's from, you're reducing the overall bacterial load in the mouth, and that's probably going to be a benefit. But that's not why we're prescribing it. So we're not. That would be off-label use. Now, if you want to use the CTX4 rinse off-label, to do that, I can't make that recommendation to you as a manufacturer. So, I mean, we use a lot of products off-label in dentistry, but that's a decision, again, that you have to make if you're going to do that. So the overall bacterial load in the mouth kills, all bacteria, kills everything. So you're going to benefit from that. But, again, that's something we just haven't worked on marketing clearance for. So that's not something that I can market or promote to you. Those are anecdotal reports, and be using it off-label, and you have to make that decision. So that is question number 8. As promised, even as I rambled on tonight, we're still done 5 minutes early, Kendall. So we've got time for a couple of live questions.
Absolutely. One of them that I think we got quite a few questions about that I think is important to address is just the side of kids and how we motivate kids. If you have any experience with that, it's a little bit different than just talking to your adult patient face-to-face, getting mom to motivate kids. And, you know, if we can't get them to comply or participate with you know, the home care routine that we're recommending, you know, where do we go after that? What would be the next best step?
Great questions. You know, I'd ask you the question, you know, how do you think we should solve that? I mean, what do we do about that? As we start to think about kids, kids are different. That's you know, now you're talking about a different kettle of fish. Comes or participation with children, certainly that's a challenge. And you know, do I experience with that? Yeah, I had 5 kids of my own, and when they were teenagers, they thought I was the dumbest thing that God ever created. So, you know, I have a little experience with kids. I now have 7 grandchildren who think I'm the most wonderful thing God ever created. So that changed probably when they become teenagers. But I'm enjoying being a grandparent for change. How do we deal with these kids and these risk children in our practice? You're not going to be successful sitting down with a 4-year-old and working them through making a behavioral change in their life. I mean, that's not realistic. We certainly are looking at factors. Certainly, these kids, until they're at least 5 or 6 years old and can spit adequately and won't swallow the products, you don't want to put them on a 5,000 part per million fluoride gel. You don't want to put them on antimicrobial rinse. So you want to be really careful about the products that you recommend. We will have an 1,100 part per million out shortly. I was expecting it by now, but but it is coming, and it's coming fairly quickly. So the American Academy of Pediatric Dentistry recommends that for those high-risk kids that they use a small drop of standard fluoride toothpaste, in this case an 1,100 part per million gel. There is a risk of fluorosis, but the benefit on this particular population of high-risk kids outweighs the risk. And so making that recommendation, so you can make that recommendation to parents in the meantime. What you need to do is sit down with mom or a responsible adult. And at times there is not a responsible adult. That becomes a challenge. But you want to get to the responsible adult and sit down and make sure that they understand. And whatever coaching you're going to do, make sure that they have radical clarity. You know, is this important to you? Your child has decay. Let me tell you why your child has decay. Let's go through the risk factors. And that risk factor form is different. You know, the risks for the children are significantly different or substantially different than they are for adults. So you need to go through and identify and go right back to look for the usual suspect. What's driving this disease? It's important for, you know, the parent to understand that if it's a function of them eating, nursing, or going to bed with a bottle with anything but water in it, you know, if they're eating well, they're doing this, you know, that's one of the challenges they got. Or if, God forbid, they're putting, like, you know, Coca-Cola in their sippy cup at age 1.5 or whatever it is, but start to identify what the risk is and get to the usual suspects. And I would tell you in children that this is the #1 disease in children in the United States. And typically the greatest risk for the child is mom in terms of bringing this disease vertically from mother to child. Also comes from dad, but you know, the research is pretty clear. Most of it, you know, happening from mom, primary caregiver. Let's put it that way. The next greatest risk is probably dietary, and then the third greatest risk is probably going to be medication-induced xerostomia. The second highest disease in our 5-year-old children is, and so they got them on epihalers, and they've got them on antihistamines, so they're drying out the mouth, or, you know, riddle, ADHD, that's going to create dry mouth as well. So typically children have an abundance of saliva and they're hard to work on. You've got children that have xerostomia. So those are really, in my mind, and again, the bacteria. So as we look at the usual suspects and apply them toward children, it's really important that the parent understand what's causing that disease or what's driving it for their child, so that they can make the appropriate behavioral change. And that's the same thing. I coach the parent the same way that I coach the child. It's like, what do you think we should do? Okay, so the problem is that your child's eating too frequently or has, the wrong kind of thing in their bottle when they go to bed at night. How do you think we should solve this? Or isn't, doing an adequate job at the home care? How can we, what do you think we should do? And, get the involved in terms of to help the child, because it's not the child going to be able to do that on their own. They really need parental guidance and supervision, and the coaching is going to be taking place with the parent. The care rate in our 0 to 5 children right now, the new CDC report that's out, we have the highest rate of decay in our 0 to 5-year-old children that's ever been reported. It's getting worse. I mean, we've got a caries epidemic, which should be an alarm to all of us, but that's a challenge. And I hope that my answers there kind of help you or give you some ideas on how to tackle that problem. But really sitting down and coaching with the parent and getting clear on what's driving the disease, finding out the usual suspect, and then getting clear the patient on what's your focus, what's your goal here. And that'll probably give you the best adherence or participation. Great, Kendall. We got for one more?
Yes, I think we do. We definitely do. We are getting quite a few questions about the cost of treatment, and that being a big stumbling block. Some people are saying that it's 95% of their patients not accepting treatment because of cost. And I would add in something that Dr. Kutsch to cover. Do you think that is not the real issue? That might be something that they kind of use as an excuse. If that is the case, how would you get around that? Or if that really is a true obstacle, do you ever experience that, and what do you do in your coaching to overcome that or to help the patient?
Really good question, and let's look at this for a second, because that comes up all the time. It isn't just caries treatment, and frankly, this is expensive. But I tell my patients, yes, it's expensive, but compared to the cost of fillings, which start at about $300, and crowns and root canals, which are going to cost you a couple $1,000, and implants, where it start at about $4,000. This fee, whatever I'm charging for my practice, is dirt cheap by comparison. So if I could prevent 2 or 3 cavities for you in the next year, and get to a point where you are healthy and you don't have any more cavities, and you could maintain a cavity-free mouth or near cavity-free for the rest of your life, this is a bargain. I mean, compared to what dentistry costs, repair dentistry, restorative dentistry costs, it's dirt. I mean, it's inexpensive by comparison. And patients all the time, what's a partial denture or implants? I can't afford that. And a month later they come back and they can't afford it. I think that our patients, we that out a lot as, that's an objection. Well, I don't really want to spend that much money, or no, I'm not interested. And it's like they may not be radically clear on that may not be their real goal, and so it may go back to, okay, so it sounds like you're not really, ready to start becoming decay-free, or that's really not what your main goal here is. Tell me what, so if it's something else, tell me what that is instead. You have to get them really clear, because when they get to the point, that I want to stop having cavities, I want to save my teeth, have few objections to the cost of the therapy. I mean, that's almost never an issue. I don't want to say it's never an issue, but it's almost never an issue. I literally have patients ask me, when I do to start, what can I do today to get started on this? When they find out that there's hope, that we can work with you, we can help you, we can accomplish that goal, I can help you through the process to get there. They want to know, how can I start? I want to start today. I mean, they're motivated, and never have I had one of those patients say to me, oh, no, you know what? No, it's $99 is too much. I don't want to do that. Or it's $159. No, I've changed my mind. Typically, when people make a decision on something, we make decisions based on, we get connected to our emotions. We make decisions based on emotion, and then we rationalize those financially. And so if somebody's telling you that, you know, they're not interested, or it's too expensive, or this or that, yeah, it is expensive, but it's a lot cheaper than the alternatives. Extractions are $300. So, and then you get to be without teeth. So that's kind of how I approach that with patients. I would encourage you to try some of your own language on that, but for the second that it may not be the real issue. When somebody throws up an objection and it's cost, that may not be the real issue. And then I try and dig down a little bit to establish if it is. And if it really, truly is the issue, you know, there isn't a lot I can do about that unless I want to give it to them. Sometimes I do that. You know, I mean, sometimes I have patients that really can't afford to do a lot of dentistry. I have one pro bono case that I actively treat ongoing all the time. So that's just part of who, you know, what I do in my practice. But you know, certainly an option for you. So I don't know what to add to that. It's a challenge, but it's a challenge regardless of what is it we're talking about in our practices. Finances are always an issue, and these are particularly challenging times for everybody. Finances, I don't want to make light of the situation. Finances are a real challenge for everybody today. So I do with that. I would share this one last data point for you, and if there's hygienists on tonight, they'll probably hate this. But I'm comfortable talking about things that aren't covered by insurance than my hygienists are. My hygienists are literally everything that they present to a patient is covered by insurance at a very high percentage. So it's never really, unless the patient's over their maximum, for the hygienist to present treatment like that, it's typically it's for them to get to a point where I have to talk about something that the patient has to actually pay for, because I'm not used to doing that as a hygienist. I mean, literally, most of what I do is not covered by insurance. So I'm very comfortable talking about costs, and it's like, yeah, it is expensive. How much it costs? You know, is this something you really want to do or not? And so we're having that conversation where hygienists aren't, and it's not strictly because they don't have a lot of experience at that, because what they do is covered by insurance. So things that we don't have a lot of experience, we're uncomfortable with at first until we get more experience at it. So you might find it more successful in your practice. Your hygienist is the one presenting those fees to them to take over and say, you know, for the dentist to take that over and say, you know, let's talk about this therapy. Here's how much it costs, and let's go from there. That might improve your acceptance rate. And over time, I think the hygienist will get more and more comfortable with that. That's just observation, and it is not judgment on hygienists. I love hygienists. So anyway.
Thank you. Excellent. Thank you, everyone, for your participation. I think we will kind of start to wrap up here. There were a few extra questions that we didn't get a chance to answer, so we will be replying to them throughout the week via email. And now I would like to leave you with this for those folks who are on with us tonight, who are new to CariFree and possibly interested in getting started or learning how to get started, or just learning more about Cambra and CariFree and CTX and all of that good stuff. Please visit the link start.carifree.com. You are always more than welcome to give us a call. If you are a current customer on with us tonight, which I believe most of you are, please feel free to contact your Cambra specialist or your coach. You can visit training.carifree.com, or again, always feel free to call us. Our phone number is 866-928-4445, and we would be more than happy to help and answer any questions that you may have. So we would like to say thank you and have a great night. Thank you to Dr. Kutsch for answering all of those great questions well.
For everybody for participating and sending those great questions in. I had a great time, and I hope that the information I share with you tonight will lend for you and stick, and maybe help you in your practice and help you with those challenges as you try and implement Cambra into your practice. Everybody have a great week.